Good morning, everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here at Insurance Syndicate headquarters, and man, we have a great show for you.
What is happening, man? Do me a solid. Comment below if you can definitely hear me. We ran a test earlier. It worked perfectly. So please do me a solid and just drop in the comments that you can definitely hear me, man. I want to say welcome back. Number one, sorry we did have some audio issues this morning, but everything does seem to be functioning properly now. We had a mic test, went perfectly backstage. So hopefully we are definitely live right here from Austin, Texas at Insurance Syndicate headquarters for a late afternoon edition of Tuesday Training. So I'm going to tell you this, buckle your seatbelts. We got a good show for you guys. We got a lengthy show for you. I'm almost out of Hennigan's, right? AEP is over. It has been a hell of a week if you have been in the Medicare industry. Man, I mean, if you've been in the life and health industry, number one, it's been busy. But if you've been in the Medicare industry, it's also been a hell of a week, right? We've had AEP going on. We had a massive tragedy that happened last week on the 6th, if I remember, or the 4th, if I remember correctly. I might be off on that date. I apologize. But man, it has been crazy. And so thank you for tuning in. But number one, this show, as always, is brought to you by DFY, the number one CRM out there for the life and health agent, and definitely the Medicare agents, whether you speak English or Spanish. Doesn't matter. We obviously do all of our Spanish and marketing. And we chose DFY primarily because all of the automations were already built. Everything was already created for us. It was a one and done, truly done for you CRM. We just plugged in our assets, hit the go button with some slight modifications, and boom, bang, pow, we've got leads, we've got appointments, and we are making conversions. So if you're out there looking for a good CRM to help you with next year, give my buddy Eric a call over at DFY, man. Get a demo and get into the groove. But with that said, man, like I said, I do have quite a bit to talk about. First and foremost, man, I'm not going to spend a ton of time on this. But obviously, like I said earlier, we did experience a tragedy this week. And I certainly didn't know Mr. Thompson myself. I knew people that did know him. I certainly have heard nothing but great things about him, of course. I think Jared Strock said it best. If you don't know Jared Strock, he's an actuary out there that publishes the Medicare Market Insights on LinkedIn. I think he does also post it. Maybe he shares it in the Medicare Monsters group. He posts some outstanding stuff. But he said something fantastic that I thought was probably the best words out there. And that was that the Medicare industry is big, but it is also small. And what makes it great is the people. May we comfort each other and rest well during this certainly dark time. So while I can't say much more on that, and I don't want to say a whole lot more, I would like to say, well, they caught the son of a bitch and they charged him with murder. So we have that going for us. But moving on, you may have seen this article floating around. I certainly posted it in the group. Very, very informative article. You may have heard that Anthem Blue Cross was doing basically a cost control measure like insurance companies do to basically prevent overbilling from anesthesiologists. A lot of people were like, here's another example of a carrier denying claims, denying service, denying anesthesia for people that are in surgery. Like they're all of a sudden going to wake up in the middle of their surgery in pain with their bowels split open going, oh my God, it hurts. That is not what is going on at all in that entire thing. It was a cost measure to prevent anesthesiologists basically from overbilling, right? And not prolonging procedures and so forth. I thought this was an awesome article and I put it in the group because I felt like it really helped paint the crux of our broken healthcare system and all the different levers that can be changed, massaged, maneuvered, played with, adjusted, manipulated to create different cost measures, health outcomes, etc. Right? And if you go through and you look through this article, I would highly recommend you read it because number one, it sets straight the whole thing that was going on with Anthem and Blue Cross Blue Shield, and they did back off on that. So anesthesiologists can overbill now and charge extra if their procedure goes longer than they had originally thought it might, right? Fairly simple is how that worked. It wasn't a situation that was going to pass more cost to the beneficiary, or a situation that, again, would remove claims or deny claims from the beneficiary or prevent care. None of that. It was simply a billing measure. But if you go through this article and read it, it's got some great stuff in here. And there's one specific quote or takeaway that I want to pull out of it and read to you guys. And I actually quoted it when I put it in the group earlier. But it says, if we want America's healthcare system to treat more patients while charging us all less money for coverage, well, then there is no alternative to forcing myriad specialists to accept lower payment rates. Ideally, we would do this through a comprehensive system of public cost controls and insurance provision. Failing that, we need private insurances. Failing that, we need private insurers to drive a harder bargain when the most expensive doctors and hospitals. When we demonize insurers for doing precisely that, especially when many of them are under government regulation to do precisely that, we aren't standing up against our healthcare sector's profiteers. We're actually sticking up for them. And I thought that even though this is an opinion article, I really thought this dude nailed it on the head. So go check that article out. It's in the group. It's on my LinkedIn page as well. You can definitely dive into that. And then next up, I want to talk about this piece that just came out from Kaiser Family Foundation. You guys know I'm a big fan of Kaiser Family Foundation. I've encouraged y'all to follow Kaiser Family Foundation. They put out probably some of the best analysis out there on the healthcare sector, and certainly the Medicare sector, the Medicaid sector, et cetera. And they put out this analysis. They put this out on December 6th. Medicare spending was 27% more. And I want to be clear, Medicare spending, not beneficiary spending, although we can definitely extrapolate from some of the points in this article that beneficiary spending was probably quite a bit more too. And you'll understand where this is going. But Medicare spending was 27% more for people who had disenrolled from Medicare Advantage than people who were in traditional Medicare. So in other words, people that had Medicare Advantage and moved back to traditional Medicare versus people that just stayed with traditional Medicare from the get-go. Right. So people that had gone to Medicare Advantage and moved back, they noticed that Medicare spending was 27% higher for those people. I'm not going to go through the whole thing, but I will hit some of the key takeaways for you. Basically, Medicare spent 27% more on average for people who were covered by traditional Medicare after disenrolling from Medicare Advantage than again for those who had stayed with traditional Medicare from the get-go. 27% more. That actually broke down to $2,585 per person. That might be a little further in this, but it broke down to basically $2,580. There it is right there. There was a difference of $2,500 per person in Medicare spending, right? The differences ranged based on conditions as well. So as low as, say, 16% if you had pneumonia, but maybe as high as 34% for people that were diabetic, right? So again, this is Medicare spending was higher if you were previously on Medicare Advantage, moved to traditional Medicare versus you stuck with traditional Medicare the whole way. The differences also range for people that were different ethnicities. And then certainly it was very specific on certain benefits. And again, those benefits wrap around what is also the three biggest gaps that exist in Medicare Advantage plans: Part B services, skilled nursing, and hospital copayments. But they noticed that when those people moved traditional Medicare, those three areas experienced, again, 27% higher spending. Skilled nursing spending accounted for the largest share of the difference in average Medicare spending per person between people, again, who were disenrolled from MA and those who continuously stayed in traditional Medicare, 34%. You can cruise through this entire piece. I'm going to get this in the group right after the show. It puts a basic little graph right here. This is what I was talking about. $2,500 per person, $2,585 higher if they were on Medicare Advantage and moved back to original Medicare versus stayed with it. And this is the average total spending. This is, again, this is Medicare spending. This isn't Medicare beneficiary spending, like I said earlier, but we can extrapolate from that that they're probably spending more money too. Had they not stayed on their, or had they stayed on their Medicare Advantage plan, at least they would have had some MOOPs and such that they could stick with. It goes through a few other details. One of the points that it makes, again, is based on health conditions. And this is here where it ranks all of the different health conditions and shows you how much more Medicare spent on these people after they disenrolled from Medicare Advantage. So, for example, people that are diabetes or have diabetes, if they had stayed with traditional Medicare, the average Medicare spending per beneficiary is $13,638. If it was someone who had a Medicare Advantage plan, disenrolled from it, and moved back to original Medicare, well, their average spending was $18,224 per beneficiary, a spending difference of $4,586 per beneficiary, or that 34% swing. And then you can go through each of these different things that'll show you how much more Medicare spending was, where again, pneumonia is down here at the bottom with actually only a 15% bump in Medicare spending versus people that just stuck with traditional Medicare. And here's the key point, and I'm going to scroll down a little further. Again, you can look at it based on age groups, which age groups were more affected. Obviously, you can see the oldest age group has the highest swing at 46% for those people that are 85 up. It goes through your different ethnic groups. Who has the biggest jump here? Dual beneficiaries. People that were full dual saw the biggest percentage of difference. So this is someone that is dual eligible. They're in a DSNP, and then they go back to just original Medicare. Medicare spending went up 61% on average for those people. Pretty crazy. And again, skilled nursing was the number one cost piece, right? Outpatient hospital, inpatient was in there as well, but skilled nursing made up 34% of where that increase was coming from. Not surprising, considering Medicare only gives you 20 days, and then you got to start picking up some of the cost on your own there. I mean, there's a lot in this article that really shows me the need for proper cross-marketing if you are signing people up on Medicare Advantage plans. There is more of a need to cross-market products to people if they're in Medicare Advantage plan than there is Medigap all day long. And this article is definitely a big evidence of that because, again, it shows you where the three biggest cost markers are at on these people. Outpatient hospital stuff, inpatient hospital, and skilled nursing facility. You can easily get a hospital indemnity product that will wrap up those benefits and then some. So if you're an agent out there selling Medicare Advantage plans, you should be taking note of how you can take better care of these people by getting them that secondary product that can fill those gaps for them. As a matter of fact, I'll just plug it now. We're going to be doing a pretty deep dive training with Hunter Gordy from United National Life. He's going to be coming up on the show here pretty soon. We don't have a date nailed down yet, but I'm hoping we'll have it before the new year. Because we do already have another show scheduled with a great guest that I'm going to talk about a bit later. But yeah, Hunter's going to come on. We're going to talk about hospital indemnity, the need for it, why to cross market. This whole article is evidence of it. So I'm going to bring it up to him as well. And we'll kind of chat about that. But we'll talk about how to lay out the product, how to pitch it properly, who you should be pitching it to, etc. So stay tuned for that. I will definitely get that announced ahead of time. And then there was one more statement out of here. I've lost it, but it really points out the problem with pre-existing conditions for these people. Here it is, right? No, that's not it either. Well, I've lost that statement, but we already know, right, that a lot of times these folks that are leaving Medicare Advantage and going back to original Medicare, obviously not only are they now increasing spending from Medicare, right? Medicare's having to spend more money to take care of those folks, but we know that given they probably have pre-existing conditions, they're probably not getting a Medicare supplement plan, which means, again, that's what I said when I opened this up. You could extrapolate that they're probably spending more money too. Moving along, you guys may actually, I know you have seen this. Unless you're living under a rock, you should have seen this piece out there. It's been shared probably 10 different times around the different groups out there. But this is a CMS memo, and I want to say something kind of weird about this CMS memo. I can find just about every memo in history that there are. I know how to search for them. I found most of them, and I'll pull them up and I'll use them. I cannot find the actual URL where this document exists. I've asked for it a few times. Nobody's been able to produce it, but everybody can produce this screenshot. I'm not trying to question the validity of this document. I'm just saying it's kind of strange. But this document shows, and this is a fact, this isn't a joke, this is true. I'm certainly not making light of it in that regards. But beginning, you'll see it highlighted there. It says beginning April 1st of 2025, Individuals wishing to use the Disaster Emergency SEP, SEP-DST for disaster. That is your FEMA disasters, right? People that dealing with hurricanes, wildfires, droughts, the border crisis. Like they've had FEMA disasters for all kinds of stuff. Any of those that exist, and I know there's some that are currently going on in Florida, they're going on in Texas, and I know they're going on in California as well. I think those are the three main states that we currently, and there's probably some other ones too that I'm not aware of, but those are the three main states that I see FEMA or SEP DST going on. It is saying that beginning on April 1st, 2025, individuals wishing to use that election code must call 1-800-Medicare to get it done. In other words, they cannot allow, or they won't allow an agent to write that SEP code anymore starting April 1st. That's right after the end of open enrollment period. And it says that Medicare Advantage organizations and Part D sponsors will no longer accept elections directly from beneficiaries using the SEP plan, right? It has to go to Medicare directly. This change is in response to concerns that have been raised by plans about the misuse of the Disaster Emergency SEP to enroll beneficiaries who were not affected by a declared disaster emergency. Imagine that. Give agents an SEP code that's easy to abuse, and of course, some of them are going to abuse it. Doesn't surprise me. And what is that going to do? Well, this is proof right here. If you abuse the crayons they give you, they're just going to take away your crayons from you. And that's exactly what they've done. However, I will say that I don't think this is really that big a deal. I think most agents are overreacting about this, and they're like, oh my God, it's more government regulation. They're taking more opportunity away from us, more money out of our pocket. Okay, fine, yes. They're not going to allow you to write SEP DST anymore. Come on, man. How much of your business, what percentage of your business is SEP DST? If there's somebody out there that's like, dude, the SEP DST makes up 25% of our business, I would be extremely shocked. If it makes up 10% of your business, I would be pretty shocked about that. There's some possibilities, and maybe it might make up a larger chunk of your business in a condensed time frame, right when that disaster hits and that condensed population. That is a possibility. And I can see how that could affect you and take away some of your income. But I feel like on the broader scope, and maybe this is only true with maybe agents like ourselves, that we sell in multiple states, right? We're not just working with beneficiaries in a concentrated area, although Texas is ripe with disaster SEP codes going on all the time. It seems like we've been under pretty close to a year-round disaster SEP these last few years. It's just not a big enough percentage of our business where I feel like it's an issue. And I feel like if they do take this away from agents, which they're going to do, obviously, starting April 1st, agents will no longer be able to submit this election code. Then I feel like it should be a net positive, because my book I should have better retention on my book of business, because it's going to prevent other agents from being like, oh, there's another 12-month SEP for disasters. Let's go misuse it, just like this document is pointing out, and go steal Merwood's business or whoever's business, your business. So I feel like the fact that you can't write it and make that extra $300, or not even that, like it's whatever the prorated amount is during that time of year, other than obviously your renewal, I figure like it should be a net positive. You should gain that money back and then some with a better retention on your book of business. That's my thoughts on it. Otherwise, just understand that starting April 1st, right after OAP is over, no more SEP DST for you. Moving along, more bad news, maybe. I don't know. Possibly. If you are an advertiser on Facebook, this is definitely going to affect you. I announced this in our group, probably 6 weeks ago or so, something like that, maybe longer. But this is from Facebook, or I'm sorry, this is from Meta, right? They're no longer called Facebook. They're the social media platform formerly known as Facebook. They are now called Meta. But upcoming expansion of special ad categories to include financial products and services in early 2025. And the article leads off, as part of our ongoing efforts to promote fairness and equity on Meta's advertising platform, Meta will be expanding special ad categories beyond housing, employment, and credit to encompass additional financial products and services. Our advertising standards already prohibit discriminatory practices from any advertiser. But starting October 24, a new ad category, financial products and services, will be introduced, replacing the previous credit ads category. Advertisers promoting financial products and services will be able to select the new special ad category during campaign creation. By doing so, they will have access to a more limited set of audience selection tools, including more limited targeting options. Examples of financial products and service ads include those promoting insurance, bank accounts, investment services, and payment services. In early 2025, right here, in early 2025, using the special ad category designation will be required for advertisers based in the United States or targeting audiences in the United States running financial products and service campaigns. Ads may be rejected if the advertiser does not choose an appropriate special ad category. So in short, starting in early 2025, and it's available to use now, if you are a Facebook advertiser advertising insurance on Facebook or Medicare on Facebook, and that includes you running Medicare educational ads like I do, like I'm in there as well. I'm not selling insurance. I'm not advertising insurance products, but I'm advertising services related to insurance. They know I'm an insurance agency. That's my business and my ad category already. So I'm going to have to now start using this. And if you are an advertiser on Facebook advertising insurance, you're going to have to start using the special ad category as well. So how is that going to affect you? Well, you noticed when it said that you're going to be given, you're now going to have access to, like it's a better thing for you, to a more limited audience targeting selection, right? A more limited one. You're going to have access to that now. What are those limitations? Well, let's take a look here. Here they are. Special ad categories for credit, employment, or housing opportunity, which is now being called the credit side is now going to be called financial services, which includes us, have limited or unavailable targeting options that you can use to find the audience to your ads, blah, blah, blah. It goes in little steps on how to create your audience, etc. Here are the targeting limitations: location, age, gender, detailed targeting and audience exclusion, and audience expansion. Location's pretty simple. You will no longer be able to target ads by country, region, state, province, city. Or you will be, but not by zip code. Sorry. You will be able to target by country, region, state, city, but not zip code. Not a big deal for me too much, but if you are trying to hyper-target zip codes, no more of that. That's going away. Age. Options are generally fixed to include 18 through 65 plus. Right? Advertisers running these ads can select different age categories. You're going to have some limitations in there. For example, I bet we won't be able to advertise to people that are 64 to 65, as an example, or people that are 64 with their birthday happening in October. Maybe I'm wrong, but we're going to have some limitations there. We're going to have some limitations on genders, have to include all genders. Not a big deal for us, I don't think. Detailed targeting audience, so certain demographic, behavior, and interest options will be unavailable. I'm not sure all of these, which they're going to take away because it just says some. The one that I'm concerned about would be my ability to target people that have Spanish language checked off. I'm of the opinion they're probably going to take it away, right? And I'm basing that opinion based on Texas. Back in June or July, one of those 2 months, Texas no longer allows you to purchase calling lists or mailing lists based on ethnicity, right? So I can't say, hey, give me all the Hispanic surnames that are in these zip codes or these counties of Texas. I can only ask for all the people that are turning 65, basically. So they've already gone to that spot in Texas, which I find kind of interesting. And then now Facebook is going to that space as well. So I'm not sure of all the different demographic, behavior, or interest targeting options that are going to be removed, but we're definitely losing some of them and probably some of the ones you're using. Audience expansion. This is the use of Meta Advantage detailed targeting, previously known as detailed targeting expansion or lookalike options. That will be unavailable. So when I read this, it kind of freaks me out a bit, and it tells me that, hey, all of this is going to increase costs for Facebook ads. However, some people that are smarter than me, because I'm pretty good at Facebook ads, but I'm not the best out there. There are some people that I talk to and listen to that help me keep me ahead of the curve. They are telling me that, hey, don't fret. If your messaging is clear, if your copy is clear, if your ad targeting is clear in the messaging, then Facebook's algorithm will actually do a better job than you can do, and you should have a lower ad spend. We'll see. And we're going to see for sure, because on New Year's Eve, that morning, that Tuesday morning, December 31st, we are doing a live training right here on this. We're going to bring Shauna Thorenson on the show. She is the creator, owner, founder of Social Waves Media. She's an absolute beast when it comes to Facebook marketing. She's one of the people that I listen to. She is going to come on and explain how this will truly affect us, how we can better get around it, right? And I believe, based on listening to her, it's like, you just got to make sure your messaging is clear. The Facebook algorithm will do the trick. Okay, fine, if you say so. So that is pretty much the news stuff that I've got. Other than that, I've got some Q&A that I want to do. If you're listening out there and you have any questions, go ahead and drop them in the comments. We're going to do some live Medicare Q&A. I have got a handful of questions. As you guys know, if you watch the show, I occasionally aggregate different questions that agents are asking around some of the different Facebook groups, and we'll answer them live on the show. And that's what we're going to do right now. So we've got this one right here that I found that says, do you know if it's possible to be approved with United Healthcare post-discharge from bankruptcy? And this is not a question that I see come up too often. This is obviously an agent asking if he can get approved as an agent for United Healthcare. Bankruptcy is usually not the biggest deal. I think it's going to depend on a lot of your other credit factors, and probably more importantly, any criminal history you may have. One thing that is true specifically about United Healthcare is they will randomly go back and recheck your background. I know they do it every year, but they randomly do it to different agents. You might be an agent with them for 4 or 5 years and never see it. And then finally one day they do a random background check on you to make sure you're still being a good boy or girl, and that you're still coloring inside the lines with your crayons. But generally speaking, if you're in the life and health space or in the Medicare space, bankruptcies usually aren't that big a deal unless it's super egregious. But usually if you've got a discharge, you've got your papers in order, whatever is done, usually they just want the explanation, not a problem. Now, you get in some of the life and annuity areas, yeah, you may have some issues there. But in simplified issue product design, it's usually not a problem. Moving on to the next one. What is the quickest way for a 67-year-old to apply for their Medicare beneficiary ID number, their identifier, if they're losing coverage on 12/31? Well, regardless of when they're losing coverage, really doesn't matter. The quickest way to apply is usually online at ssa.gov. That's usually the simplest way, right? You can go on there, create your account, get it all set up, apply. There's a giant button right in the middle of the screen that says apply for Medicare benefits. They can click that, run through the screen. I will say they've made it a little lengthier because now they've added on there's two of them. There's the ID Me verifier, and there's one other one. I can't remember the other one that they're using. I use ID Me. And I think most people are probably familiar with that. But they make you kind of create that profile first. But then other than that, it's a snap. The only time this wouldn't necessarily be true is if their Part A and B dates are different. If their Part A and B dates are different, this would change because they'll need to basically apply for Part B via paper. But generally, if they're brand new to Medicare and they're getting their, like as this question asks, they're getting their Medicare number for the very first time, best way to do it is right online at ssa.gov. You can also call the national phone number for Social Security, but eat your Wheaties because that's going to be a long call. And if you do have a Social Security office in the county of your residence, you could also run in there and knock it out. They might kick you out and make you schedule an appointment, though, depending on how busy they are. Moving along. Client applied for Medicare supplement directly on Cigna's website. Does anyone know if I can get myself assigned as AOR? Unfortunately, you cannot. Cigna has a direct product sold to consumer that is, unfortunately, I believe it's about 5% cheaper plus or minus than what we can offer as agents. They're the only carrier that I'm aware of that has a different price point on their direct-to-consumer version. But you can't sell it, and if they do buy it, you cannot become AOR. So that client is now Cigna's clients, and they're the ones getting paid. Sorry to give you the bad news. Moving on. Hey, I got a T65 in December of 2024. They chose a give back plan with a 12/1 effective date. The money never came in December. Who do we call? Well, generally speaking, you would contact Social Security about that. They run all of the Part B premium cost reimbursements, etc. However, usually it takes as much as 90 days before those give back plans kick in and start making a difference on their Part B premium. So in this case, be patient. It probably just hadn't kicked in yet, right? Maybe another month or two, but then it will kick in, and Social Security will retro and go pick up that other money. So they'll get their December money. They're just not going to get it immediately. Have them be patient if you can, which is advice if you are out there anytime you close a Medicare Advantage give back plan. And some of the give back plans out there are great. Like, I'm not going to advocate against them. I wouldn't try to sell them, as a crutch, right? You need to make sure you're doing what's in the client's best interest. But if that give back plan is definitely in what you and they, more importantly, they feel is in their best interest, then write it. But just tell them when you close it, hey, Ms. Jones, we got you signed up for that give back plan. Just give you a heads up. Usually takes about 60 to 90 days for Social Security to reconcile that and reduce your Part B cost, but they will go back and pick up the months that they're behind on. Don't sweat it. Next in line. Hey, I'm selling a Humana plan. And I asked the lady if she's receiving extra help, and she doesn't know. How do we figure that out? Well, probably there's a few tools out there that will tell you if they're Medicaid eligible, LIS eligible, etc. Probably one of the easiest ones is on Jarvis. If you're appointed with United Healthcare, doesn't matter if you're looking at a Humana plan or whatever, they have an eligibility check that will also tell you. It's super easy. You just got to have a Jarvis login. If you don't have that, if you have Sunfire, I'm not sure if Connecture does it at all, but I know Sunfire has that option as well. And then UHC is probably one of the better ones. You can also call in to a lot of the carriers with the client's information. You're going to need, depending on the carrier, they'll probably ask you a few items. Most likely you'll need their date of birth and their Medicare number. If you have that, you should be able to get an answer properly. Fairly simple. Moving along again. In regards to Medicare Advantage plans, what is the difference between a PPO and an HMO POS? Well, there are a few differences. There's actually about 5 differences. First one is going to be provider flexibility, right? A PPO plan will technically allow you to see any doctor or specialist, whether they are in or out of the network, right? But going in network always is less money. There are some conditions on that, and I want to be real clear before I just say that a PPO allows you to see any doctor that you can. It will allow you to see any doctor that you want if, number one, that doctor accepts Medicare. Number 2, he is accepting new patients. And number 3, he's willing to accept the terms and conditions of your PPO. Right? As long as those 3 check out, you can see any doctor you want. HMO POS is still going to operate a lot like a standard HMO, but that point of service option allows you to see some out-of-network providers. Obviously, it's going to be at an elevated cost. Okay, fairly simple. The second one is going to be referrals, right? You don't need referrals for PPOs. You can go see any doctor you want, just like I said, as long as those conditions are met. So you get a lot more direct access. Whereas on an HMO POS, you will generally still need a referral from your primary care before you can go see a specialist. Costs, there are some cost differences. PPOs tend to have higher premiums. They also tend to have higher MOOPs and higher out-of-pocket expenses, especially on the out-of-network side, whereas HMO POS will have lower premiums. Still going to charge more when you go out of network and use that POS option, that point of service option. Out of network coverage, PPOs is going to give you a much broader selection because, again, you can see any doctor as long as those 3 conditions are met. He accepts Medicare, he's accepting new patients, and he will accept the terms and conditions of your PPO. So POS will give you a little bit more out of network coverage, but not nearly as broad, and typically more expensive when you jump out of network. And then network rules, PPOs, for the most part, there are some exceptions. I can't remember now off the top of my head if it was California or Florida, but there are a couple of states now, as I remember, and it may just be a couple of carriers. I'd have to go back and look at all my rules that are now requiring a PCP on PPO plans, but most of them don't require you to set a PCP when you're doing that enrollment, whereas an HMO or HMO POS in this case will always require you to select a primary care physician. If not, it's going to auto assign somebody. You can, of course, change them, but you want to make sure and get that locked down up front. Those are pretty much the basic differences. But I would say, the biggest thing is going to be provider flexibility. When you have that HMO POS, if you want to go out of network, you can and get a little bit of that direct access at point of service, but you will certainly pay a higher cost. Fairly simple there. Moving along. This one jumped up in the group. Does anyone know of good dental insurance in the state of Washington? Dude, I sell Emeritus. They're everywhere. I think some of the responses I saw on this was Emeritus and Delta Dental. I know that Washington is more limited on product selection, especially in some of the ancillary products. This is true, I think, on the entire West Coast. But certainly Emeritus is up there, which is what I write, and Delta Dental is up there too. And if you need access to Emeritus, give me a holler. I'd be happy to help you out. I got one of the national contracts on it. Next one up. I am in Florida, and one of my clients had her plan changed by a call center last minute, according to her, without her knowledge. Can I use an SEP to change her back for 1/1/2025? This question was asked because we are now outside of AEP, and they know, hey, I can't use AEP to get my client back into the plan that I originally tried to get them on. So can I use an SEP? You could possibly. The only SEP that you might have access to, because you won't be able to use a disaster code SEP, not because they're changing it April 1st, but because that SEP would only apply if that person hadn't already used the most recent election period, which obviously in this situation they have. So the only SEP you might be able to get approved would be if you had that client call and complain to Medicare and argue and try to get that done. Then that might get you an SEP to get them back in the original plan. I usually don't advocate for that. It would have to be in a super egregious situation before I'd advocate for that, because complaints to Medicare do not look good on us agents. It just brings down more regulation. And I'm kind of the opinion that in this scenario, they might not even approve that SEP here because OEP is just 20 days away and you can flip them right there instead. So you can use OEP and get them back in your book for February 1, but the only SEP that you might be able to use in this scenario would be having them complain to Medicare and get a special exception that way. So I'll leave that one to you. Next one up. My client is 73 and enrolled in Part A, but leaving her employer's credible coverage 12/31/24. She is enrolling in Part B effective January 2025. Can I enroll her in the MA plan now? Yes, you can for a January 1 effective date, 100%, right? And as a matter of fact, when they have different Part A and B dates, when the Part B date is delayed after Part A, you have to get that enrollment done before that Part B goes effective. And if you don't, well, then you're stuck like Chuck until the next AEP or some qualified SEP, depending on where they're at. So yes, in this case, you do want to enroll that person now, and their plan will go effective with their Part B on January 1st, 2025. Next up to bat, which company did you use for cancer insurance and why do you like it? I have 3 that I like, one above all the others. The one that I prefer the most is Mutual Omaha's product, and here's why. It has the best darn rates I've been able to find for a straight lump sum cancer product. And maybe we should start there on this question and just go all the way back to the beginning. First, I'm always going to choose a lump sum cancer product and not a cancer treatment product. I cut my teeth selling cancer treatment products 21 years ago now, right? A cancer treatment product will give you like an indemnity plan. It's going to pay you a little bit of money every time you get a certain type of treatment for your cancer. And you're only going to be allowed to get the types of treatment that plan approves, right? Which often is usually radio and chemo. They may not cover stem cell. They may not cover proton beam treatment, etc. So and you're going to get a little bit of money at a time, right? You might get 500 here, 300 there. You might have a first diagnosis benefit of a couple of thousand on a plan like that. But I'm going to prefer a lump sum plan that gives them one big fat check. 10,000, 20,000, 50,000. I actually have 100,000 on myself, and Grace has 100,000 on herself for cancer. Both of us, again, with Mutual Omaha, that was the plan that we chose, primarily because it is covers in situ, offers us lump sum so that we'll get one check. We can spend the money however we want. We don't even have to get treatment. All we got to do is turn in our diagnosis for cancer. And then we get one check. We can spend that how we want, right? We can go get stem cell treatment. We can just go do holistic stuff and meditate under triangles and paint our face green and get acupuncture if that's what we want to try to do. We can move to the Wudong Mountains of China and hang out with the monks. We could put it all on red at the casino. It's our money. We can do whatever we want with it. I like that because, again, I'm a freedom junkie. I want that freedom of choice. I want to be able to get the best level of cancer care that I can get. A lump sum plan provides that. It gives me one check for amount that I can use to get the care that I want, not what the insurance company tells me to get. Now, the other reason that I choose Mutual Omaha because they have the best rates that I can find for a lump sum cancer product that has all the benefits and includes in situ coverage. Aetna would be my secondary choice. Same concept, lump sum, includes in situ benefits, etc. That one is just slightly more expensive. It's actually, it's for about 10 or 12% more than Mutual Omaha. It's a little higher in price, with one exception. If you're writing a married couple, cancer insurance for both of them, a couple's policy, if you will, and the one of the spouses is considerably younger than the other one, well, in that scenario, I might write Aetna because they will base both premiums or the joint premium on the younger spouse. And that sometimes beats Mutual Omaha. Otherwise, I'm going to write Mutual Omaha all day. The third one that I offer is with United National Life. They do have a good product as well, albeit quite a bit pricier, in my opinion. But that's where I go with that. Next one. This post stirred up a lot of conversation in one of the groups recently. It is way better to have an MAPD and a long-term care policy than a Medigap and no LTC. Well, that's certainly an opinion, and that's not necessarily wrong. But way better than what? He gave one example. There are certainly a lot of ways to skin this cat. You know, I can argue that it might be better to have an MAPD with a fat hospital indemnity and a home health care policy. You know, that's a little more streamlined, doesn't quite cost as much, something like that. I might say that it's better to have a Medicare supplement and a life insurance policy with the living benefits rider for long-term care. I mean, there's a bunch of ways to do it. This is super opinionated. Again, the dude is not wrong, but he's also not necessarily right. So, you know, there's a lot of ways to do it. I think what's most important to understand on statements like this or concepts like this, right, is you have to understand that, number one, Medicare, specifically healthcare in general, and certainly Medicare, is an extremely complex healthcare problem. There's a lot of levers that you can pull on, a lot of ways and products that you can put in to build a healthcare package. And I'm of the opinion that you are doing your best work if you are custom designing a critical benefits package for them that takes care of all their levels of healthcare for the future, as best that you can do, as best that they can afford, right? It takes care of the base level, drugs and doctors, your daily drivers. It takes care of the possible outpatient surgeries and accidents. It takes care of hospitalizations. It takes care of critical and chronic illness, and certainly catastrophic levels as well. So if you can build all of that in, the goal is to build it in the best way you can to cover all of those bases, regardless if it's Medicare Advantage or Medicare Supplement or LTC or home health care and short-term care and hospital indemnity. Doesn't matter. Your job is to build that as best you can, where you can get the biggest bang for your buck in risk mitigation, right, and reduce their out-of-pocket cost that still fits their budget. That's my thought process there on that. And that is pretty much it for the day, man. That will close it up for Tuesday training. I appreciate you guys tuning in. Sorry again that we had some issues getting the show kicked off this morning. I have no clue what was happening. I didn't catch it. Joe caught it on the back end. He's like, hey, for some reason, I'm seeing an error from StreamYard that shows they're having audio problems. So it wasn't us. We have the exact same setup we run every time. We just turn it on, hit the switch, and get go. But for whatever reason, we couldn't get the show off this morning, but here we got it out for you. So go back. I know that viewership was a little lower because this is not our normal air time, but please go back, check it out. Check out the rewatch either in the featured tabs or on YouTube. And if you haven't ever subscribed to our YouTube channel, please go subscribe to the YouTube channel. You just go right there to the Insurance Syndicate, click the subscribe button. We would super appreciate it. You get access to all the long form content, all of the different videos. The playlists are all separated out Monday, Tuesday, Wednesday, Thursday, Friday. Right. So if you're like, and if you're not watching Luke's show on Monday, you're missing the boat. But you got his playlist built, you got mine built, Winning on Wednesday, etc. You can go there. It's super simple. And thank you to Lily Davies, our producer behind the scenes, that puts all that together for us because she handles all of that. And I super appreciate it. Thank you so much. So thank you guys for tuning in again. And as a reminder, we got 2 superstar shows coming up later this month. We got Hunter Gordy from United National Life going to come on. We're going to talk deeper about cross-marketing, hospital indemnity, home health care, cancer, etc., and what their portfolio looks like and why you should pay attention to it. And then we're also going to have Shauna Thorenson from Social Waves Media. She's coming on the 31st, that Tuesday morning. We're going to talk about this Facebook thing coming up with the changes in the special ad category and how you can navigate it better. So we'll see you then. Have a great rest of your week. And be sure to tune in tomorrow for Winning on Wednesday, 9 a.m. sharp.